Thank you very much. It's a pleasure to be here. Thank you for the invitation. This is the topic is for below the knee crossing techniques, and there's not a whole lot of data on standardizing these things. These are my disclosures. So if we, if you look at even SFA treatment or simple lesion that Dr. Hana was dealing with, there's still not a standardized way to treat those because of the options that are available. So it's even it's even more problematic down below the knee because there is such a lack of data. So if you look at the steps in crossing a CTO below the knee, first is the access, common femoral, ipsilateral, contralateral, pedal or radial or bidirectional approaches, and then the choice of wires and catheters. The wire strategy is important, the type of wire, and then escalation, de-escalation of the wires. And then the techniques of crossing, once you've chosen those things. And then once you've done all of that, is the post-crossing therapies. What do you do once you cross? So now let's look at each one of these and see what can be standardized, what is standardized, what is not. So in terms of access, is more or less it is standardized, except radial. A lot of us I'd rather not go radial for CTOs below the knee. But most I think people would approach this from ipsilateral common femoral if that's access, if that is available, and depending on the patient's body habitus and availability of inflow disease or none, then you go contralateral or pedal access. There's been good discussion on the tibio-pedal access, so I won't get into that. In terms of a wire and catheter selection, it's highly variable. And if you talk to 10 different people, operators, experienced operators, you're going to get 10 different answers. And that's because there is a multitude of appropriate wires and catheters available for this. Techniques of crossing is variable but evolving. I think people are approaching to the same type of technique, and you'll see some of it in terms of cases that most people would use, but still the wire variability determines the technique. And then post-crossing therapies are definitely evolving, and the data is emerging as to what works best and what doesn't. So let's talk about access. Ipsilateral, if you have no aortoiliac common femoral or proximal SFA disease and the body habitus is okay, patient doesn't have a large panus or obesity, that is the preferred approach. Contralateral common femoral is if any of the problems exist above. Tibio-pedal, usually in combination with antegrade access. You've seen multiple cases and heard multiple talks this morning about it. The disadvantage as the pedal access or tibio-pedal access is the only access that you can't get complete angiography. Often you need multivessel treatments that's best done antegrade. Radial approach for us, at least, it's a last approach for CTOs. And if you look at a case such as this, you know right up front that you're going to need multiple accesses, not just antegrade access. A case like this that crosses the popliteal and you have the anterior tibial reconstitution, then you know you're going to have to use more than likely have two access, and would be pedal and antegrade access. Or if you have flush occlusions of the tibials. There's pretty good data in terms of tibio-pedal access and the success rate. As you can see, the recanalization success rate improves significantly when you have a tibio-pedal access in addition to antegrade access. So in terms of wire and catheter selection, it's important to know what task we're working. Are you going to navigate tortuous vessel or irregular lesions? And if you are, obviously, that takes you in a certain direction in terms of wires and catheters. If you're crossing, which is what we're talking about today, configuration of the cap and body of CTO, and then whether it's fibrous, calcified, and the content of the CTO matter in terms of your wire selection. So lesion types need, in terms of escalation, de-escalation, in terms of wire selection up front. Stenosis, obviously, thrombotic, fibrotic, or highly calcified. very different type of approach, right? Soft tip approach, heavy tip load, and then heavy tip load, thicker coil when you're going through calcified lesions such as this. Some of the trade-offs are obviously heavier tip load wires improve penetration but reduce your ability to navigate the wire. The thicker core improves support but hard to retract if false passage is created. That's why frequently we don't like 018 when you're doing CTOs unless you really need that pushability and body. And then hydrophilic coating improves lubricity but reduces the tactile feedback. And nitinol is more robust but reduces the ability to find torque control. And sometimes these, you go through CTOs and you may go through 4 or 5 wires that do this, and sometimes the tip of the wire is important to be robust. Also remember, as you're crossing a CTO, it is possible that you may have these hibernating lumens that would make, actually, if you identify them, that it makes crossing a lot easier. You don't have to go subintimal. You're trying to do a short crossing and then de-escalate and then re-escalate as necessary. So you break the cap, you navigate the rest of the time, and then cross again. Goes back to that issue of navigation versus crossing. And sometimes de-escalation is required, and I'll show you a couple of cases. Now, if you look at this, you say, okay, well, this is a long occlusion of the posterior tibial, and we have reconstitution down here. But then if you do a longer injection and late image, you see it's actually a multitude of stenoses, short segment occlusion. So much easier to cross this than the other one. Techniques of crossing, as we talked about, highly variable. Not all crossing techniques or wire catheter combinations will work in all situations. And switching techniques and devices mid-procedure is not uncommon and below the knee. And familiarity with all of these are actually is important. If you look at this, here's the perineal, the anterior tibial short segment occlusion, just above the posterior tip, just above the dorsalis pedis. In this case, we're using a loop catheter technique, but that didn't work. It worked only half the way through as you come. We couldn't break the distal cap of that. And so at this point, you pull back, you change, and you go with a hydrophilic wire and try to break the cap that way. And then, obviously, the angioplasty is done, and the treatment is complete. In this case, as you can see, it's a 91-year-old, multiple toe ulcerations, multiple lesions. Here it is at perineal occlusion. And then our target is obviously anterior tibial in this case. And trying to get through that occlusion, we had to take a different strategy, going from a heavy tip wire and then switching back. The problem with heavy tip wires, they tend to go in one direction. As you can see, we came down here. At this point, we switched the wire and switched the technique into from a heavy tip into a less heavy tip wire, and then cross easily, as you just saw. When the perineal and the tibio-perineal trunk were treated, we got into the anterior tibial, and we used the absolutely opposite technique that you just saw we used here, because it is highly variable. And also remember, when you do angiogram, make sure you recognize the true lumen, because if you fall into the false lumen, which is right there, you're going to be using reentry devices and things of that sort, which is difficult to do. Here you can see you can actually find the true lumen right there, and you can navigate and go a lot faster than you usually do. And here it is in the same area, but we got there and we couldn't re-enter with a regular tip, and so the heavy tip wire was used, and you use the drilling technique. The drilling technique works really well. You just have to have the patience to find that area that you need to drill, and drill technique, and then you'll fall into the true lumen. We're still going in the wrong direction. It's going to take a while. Yeah, let's go over here. There it is. You just have to have some patience to do that. And then the angioplasty, of course, you treat the patient and you have 2-vessel runoff. In terms of CTO reentry devices, there's a number of these devices out there, but they're really not optimized for peripheral, for below the knee. Most of these are designed for above the knee. However, anterior is one that sometimes works below the knee. Here's a vessel that we're trying to get into into the perineal, had a hard time crossing at both ends. Here's an anterior, and we used it, and you can get in an angioplasty and get your vessels going. In terms of post-crossing therapies, we said it's evolving. Angioplasty is the most common device used. Atherectomy, obviously used in most outpatient labs in the US. It's really not outcome-driven. Drug-eluting scaffolds, however, below the knee are supported by level 1 data, and there are reimbursement codes for them. And I want to show you something here that is interesting, that here's a patient that was treated with a popliteal into the trifurcation, and this was reconstructed with drug-eluting stents, as you can see here. And here's a patient a year later, as you can see, the pop is out. Those two stents are still open. I mean, this is unusual. Here's another case, drug-eluting stent placed into a collateral in the perineal. And this went down, and that's a perineal. And you can see that into the collateral, a year later, that's still open. And here's the collateral. And here's another case, and a patient, again, reconstructed. This is gone down, the perineal, and outflow is small collateral, and the drug-eluting stent is still open. I think obviously there is level 1 data, so for us, it is drug-eluting below the knee. So in conclusion, we take a hierarchical approach. In terms of access, ipsilateral common femoral is our first choice, contralateral with tibio-pedal access as needed. In terms of crossing, antegrade catheter wire, bidirectional, frequently bidirectional, and then you use a variety of rendezvous maneuvers to get through. Specialty CTO reentry devices is our last option if any of these don't work. In terms of treatment, angioplasty and in our lab, drug-eluting scaffold are very common. We use it in about half the patients that we treat below the knee. Thank you very much.